So good evening, dear Chairman. Good evening, dear colleagues. I'm going to present how we perform M-TEER. Here's our Katsianos Hospital heart team. A mitral valve transcatheter edge-to-edge repair got a CE mark in 2008, FDA approval for primary MR in 2013, and for secondary MR in 2019. Over 150,000 patients around the globe have been treated with M-TEER to date. The speakers before me analyzed thoroughly the criteria that we use when we assess patients with severe MR. It's always vital and essential, the heart team assessment for our patients. We have specific criteria, established criteria, which my colleagues, the speakers before, analyzed thoroughly. So I'm going to move on. Is it a safe procedure? M-TEER is a very safe procedure with a low rate of serious complication despite the high burden of comorbidities of the treated patients. Which device? We have two devices, the MitraClip and the Pascal Precision. I'm going to move on since we have already heard in detail the characteristics of these devices. So here we see both systems. Intraprocedural imaging and guiding. Imaging techniques include traditional 3D, color Doppler, and 3D imaging approaches such as glass view and true view. The transeptal puncture, as we heard before, is performed starting from a bicaval view using an X-plane to localize and adjust the position of the needle tip in the anterior-posterior plane. Fusion imaging is useful during catheter steering towards the mitral plane, and valve crossing and grasping is usually performed on an intercommissural view using an X-plane. So once we are there at the above the valve, we have many possibilities above or under the valve for leaflet optimization, simultaneous grasping or clasping, or a staged leaflet capture. We have seen the video already of how the system works in terms of simultaneous or separate grasping. So well begun is half done, so it is very important to begin with that we are sure that we have punctured correctly the vein. Ultrasound guided. We should not be above the inguinal ligament in case of a complication because we won't have the option to compress the vessel. And furthermore, we should not be very distal from the inguinal ligament since we will have difficulties inserting the delivery system. Of course, if we have done all perfectly, we should also take care of other possible factors. In this case, a recent case of ours in Katsianos Hospital had a filter in the vein, in the inferior vena cava, which we passed by without problems. Here we see the phlebography. And we proceed with an SLO catheter. We use an SLO catheter for the transeptal puncture. Since we are there, of course, we have to take care of other factors, such as pacemaker, electrodes. We usually have to take care to be usually on the septal side. We should not interfere with the pacemaker electrodes, since when the delivery system is there, we might dislocate the electrode. So we have performed our transeptal puncture. It is very important to steer our catheter correctly towards the mitral plane. We should not traumatize the atrial wall. And when we are at the level of the mitral valve, we check the clasps, and we can move, also have the possibility to move medial, lateral, or posterior, anterior. In the 3D, we check the perpendicularity and the clocking of our device. We follow the anatomy of the mitral valve. We should follow the anatomy of the mitral valve. And we see here schematic how we can move anterior, posterior, medial, and laterally. So in this video, we see a P10, a simultaneous clasping on the right side. And then we proceed with closure of the device. We assess the residual MR. We see a jet lateral from our device, mainly. Since we were not very happy about the leaflet insertion, we correct this at the beginning of the posterior leaflet, as we see at the right side of the video. And then at the anterior leaflet, we see now the clasp falling down. It is very important that we see that the leaflet is until the very end of our device. We have to see it and not assume it. And of course, we see a very nice bouncing of the clasps. So we have closed our first device, and we assess the residual MR laterally. We're satisfied with the first device, and we proceed. Then here we see the device is free, and we proceed with the second device, Pascal Ace, laterally to the first one. We adjust the clocking. We see the two devices almost parallel to each other, and this is how we have passed through the valve. We have to say that we prefer at Katsianos Hospital, Dr. Sparias, to pass mainly with a closed device. Of course, there is a possibility to pass through the mitral valve elongated. Mainly, we prefer to pass through the valve with the device closed. And elongation, we use elongation if we are under the valve and we want to do slightly maneuvers without affecting the chordae. So we see the second device clasping, and we close the second device and assess the residual MR. We proceeded with an optimization of the posterior leaflet. We see the leaflet coming up and then falling down. And closure of the device. We see how harmonically the two devices are next to each other and they move. We assess in 3D also the residual MR. We were satisfied, and we release also the second device with a very stable outcome. Also in echocardiography with residual MR, grade 1, I would say. This is a final 3D appearance of the mitral valve with a mean gradient of 2 and with a very nice outcome, we would say. Of course, we are not yet finished. We should retract. The catheter should be straightened. It is very important to retract a straightened catheter through the septum because otherwise we could traumatize the intra-arterial septum. We see here that was the patient that I showed before. We go through the filter without any problems, and the patient was really happy afterwards. Thank you for your attention.
Thank you very much. Excellent presentation and very nice cases. We have time for one short question or comment. Maybe the colleagues from online, they want something to add. Otherwise, we are going to close the session. Okay, so we're closing. Thank you all for the nice session that we had here.
Thank you.